At this point, I want to insert a huge disclaimer. This is for illustrative purposes only. We know in the world of care coordination that care coordination does not happen concisely between the hours of 8 and 5:30. More times than not, and I'm sure Frank can attest to this, a lot of times those crisis interventions, they occur when you're probably on your way out the door to start your weekend and someone is having a crisis. But what we wanted to do here was just to lay out some general examples of what care coordination activities could look like. One other thing I wanted to point out too, one of the primary purposes of a health home is to support the care coordination that's taking place on the medical side with the patient-centered medical home. So again, I want to reiterate, we understand these limited hours are just for an example only, but really a health home or a care coordinator is responsible providing for what we call enhanced access to care. So it wouldn't just be between the nice business hours of a day. I won't read through these, but it really plays well with the follow-up questions Kazi had on the episode side. Let's say, for an example, using this illustration, this was an ODD client. And if we're talking about the use of medications, this would be a prime opportunity for the health homes or the care coordinator to share those evidence-based practices with the clinician or with the patient-centered medical home, just to inform everyone that in true terms of episode delivery for ODD, we're talking about not using medications to manage that condition. So you can see the episode side is very much tied to what would happen on the care coordination side of the house. This is another example. What we decided to do here was to provide a specific general walkthrough of what health homes activities could look like. And I won't read these to you, but you can see what the example scenario is here. The one that I'd like to point out, what will be crucial to the success of a health home or care coordination services will be information sharing. And if you'll look at that second bullet point where the individual presents at the emergency department, in the future world that we envision for care coordination, we're hoping to utilize health information technology. So a lot of this information can be shared electronically and not have to rely on someone picking up the telephone to notify or send a fax over to notify. We know that that's not the optimal way of sharing information. So future perfect end state would be these notifications would occur electronically. Health home care coordinator would go into the office, boot up the system, and would receive automated notifications of who has presented in the ER. And then the health home's care coordinator could then follow up with notifying the other healthcare providers because what's critical to this process working is information sharing. The one thing we did not include on this slide that we will need to incorporate is the notification of the patient-centered medical home, if that hasn't already been done so. So again, you can see the services rendered by any provider along this continuum is only as good as the information that they receive. This is just another way of showing how the different roles of the health home care coordinator, the patient-centered medical home, and other providers that are a part of that care team would interact and engage with each other to provide care to the individuals that they serve. Again, this is not meant to be exhaustive. It's not a comprehensive list of activities, but just to get the wheels turning and to start the discussion on what those health homes activities could possibly look like. Keeping in mind, again, this is just an example, and it would look different for any different client that would be receiving health homes or care coordination services. The last couple of slides that I wanted to talk through, and you will be hearing more about the developments that are occurring on the patient-centered medical home side of the house. What we're trying to do within the department, seeing that it's critical to have some sort of collaboration or linkage between the care coordination efforts happening on the patient-centered medical home side versus what's happening on the health home side, we want to start introducing what some of the engagement activities will look like between those two parties. And this is just one example we used depicting what would happen with a breast cancer screening. What I like about this page, we've depicted it pretty much as a puzzle piece. And if any of those pieces are missing, you can only imagine the missing critical information. You have to keep in mind one of the goals that CMS would like to see happen from this care coordination initiative. I mentioned that they would like to see patient engagement increased or improved. Of course, they would like to see better utilization of healthcare resources, financial resources. But lastly, and I think it's most important, they would like to see the health outcomes of the individuals receiving these services improve. So what's critical is that care coordination is highly coordinated between these two entities. And lastly, here's another example back using the medication management example for an individual with schizophrenia. And there again, you can see if there's a change that happens in the medication that's being prescribed, that all entities need to have that information. So not only the medical care plan can be updated, but that integrated care plan can be updated and that information disseminated out to all other parties. I think that wraps it up for the information we wanted to present today on health homes. Just to give you a quick overview of what our next steps are. We will continue to refine and hone in on what the target population will be for a behavioral health home, and we will continue to have discussions about what the health homes activities will look like, especially in terms of what that engagement piece will look like with the patient-centered medical home. And that care coordination component. And then we will move into discussing how will we know we're being successful. So we'll have to start talking about what quality measures should be incorporated as a part of a health homes model. And of course, we will talk about provider requirements, who will be best positioned to serve as that health home. We've talked about, we know the behavioral health providers will be involved in the care coordination delivery. But what the specific requirements and certification process will look like has yet to be developed. And lastly, we will talk about how do we reimburse providers for providing this enhanced care coordination.
I was wondering if I could go back to the episode, the ODD episode of care, and ask a question briefly. And I apologize, I arrived late, so I may have missed this. But in regards to the ODD episode of care, was it already discussed if you had clients that were inconsistent with treatment? Very early on, you saw that they were not going to engage with the guideline concordant care of weekly sessions, and they were to discharge, go to another provider. Has there been any decisions made regarding, does that episode of care continue for 90 days, and then after such time, then if they are willing to re-engage and focus on that as a priority, then you would re-engage them and start a new assessment for ODD?
So if I understand the question correctly, then it's if you have a client who starts treatment with one provider and then decides that it doesn't feel right and then switches to a different provider and then carries out the rest of the program?
No, if they're not successful with carrying out the program, with the guideline concordant care being, a minimum of 10 sessions. Does that count as an episode of care if they do not comply and complete the 10 sessions? Do they need to wait till that 90-day period is over to then re-engage?
So not necessarily. So the episode will be 90 days no matter what. And so that's how the episode's going to be defined more so than when engagement happens. And if, let's say, in that 90-day period, a provider has less than 10 treatments, it would still count as an episode. What it would not count for is gain sharing. because the purpose we wanted to do there was, to make sure that treatment was at the right intensity. And so if it's less than that, then, it still counts as an episode. Payments are the same. It's just that it wouldn't count for gain sharing eligibility. That answer your question?
I think that preliminarily that does. I had another question in relation to that. The draft proposal that was set forth in December also mentioned the services, the RSPMI services would be continue to be delivered as they are now, as long as they're in guideline concordant care. But it only mentions in that list collateral MHPP services or intervention specialist services. It makes no mention of intervention by the MHPP services. Is that going to be a service that's paid for, or is that a service that isn't provided, it's not part of the guideline concordant care?
Those services will continue to be paid for exactly the way they're being paid for today. And so it's truly up to the PAP in terms of what, they believe, the appropriate treatment is, and having them align the services to what guideline concordant care is. So, that's it. That rests actually with the PAP and not anywhere else.
In both the ADHD and ODD episode, you've got included in the treatment is parent-teacher behavior support. Do you envision there ever being funding for that activity, or is that just up to the provider to do on their own out of the reimbursement they get for the services that are reimbursed?
Yeah, we actually talked about that earlier this morning when we were meeting. There is money embedded in both episodes for that kind of treatment, because we think it's a very important part of it. I think we said I think it was about $300 could be used for that kind of parent-teacher kind of education.
But how would the provider access that money? Is there a procedure? Is there going to be a procedure code for that?
Back to you on that one.
Oh, okay. Second question. On page 10, or 9 and 10, where you did the average cost distribution for the ODD episode, I realized for ADHD it mattered more because you used it as the basis for level 1 and level 2. But I'm just curious, did you look at the difference between the distribution for RSPMI PAPs and individual practitioner PAPs?
Yes, we did. It's not in this slide, but we did look at that. And actually, the distribution showed that about 98% of the care was being provided by behavioral health providers, and probably the rest of it, 1-2%, by licensed mental health professionals.
Okay.
So
this essentially is an RSPMI distribution.
Basically,
last question. Yeah. On the page you like, on page 19, that has all the little houses.
Yes.
The health home, the house down at the right, well, I guess the same about the one above. It has example providers. Are you saying that the providers in that list are the ones who may be providing services for people who end up in this category, or are you saying that list of providers are the entities that are potentially eligible to be health homes?
And it's a list of example providers who would provide that more intensive level of services in that bottom house, not specific to the health home services.
Okay, so these would be providing the behavioral health, the direct care services.
Exactly.
Thank you.
I wanted to know, because we're talking about lots of coordination, so how are we, and you do mention about HIT, so the information technology, does all the providers have an EMR system and can coordinate the services properly? I mean, where are we with that? Or
I'll take that one. Obviously, we recognize that the more data and information that we can share, the better off we'll be, both with episodes and health homes. But we also recognize that not all providers today have EMR systems. That's one of the reasons why we're actually using the portal to help with that exchange of information. In most cases, about 90% of the information that we'll need for episodes in health homes will come from claims data, but there are a few key pieces, like we mentioned here, that we'll have to submit through the portal. In the future, our hope is that as EMRs expand and there's a greater use of the health information exchange in the future, more of that can be submitted electronically and not have to rely on portal submission. But at this point, we have made that available just to help facilitate the electronic medical record access.